Hi and welcome to the Part 2 e-module training of Adult Asthma Management in Primary Care. This module is created to guide you in managing of asthma in adults at primary care level. The outline of this module includes management of asthma exacerbation in primary care and a case scenario. Now, let us discuss management of asthma exacerbation in primary care. Acute asthma exacerbations are episodes of worsening asthma symptoms and lung function. Symptoms like shortness of breath, chest tightness, wheezing, and coughing. They can be the presenting manifestation of asthma or occur in patients with a known asthma diagnosis in response to a trigger such as viral upper respiratory tract infection, allergens, air pollution, or other irritant exposure, lack of adherence to controller medication, or an unknown stimulus. How do we assess when a patient presented with acute asthma exacerbations? History and examination should be performed along with the initiation of acute treatment. We should ask the time of onset, severity of symptoms, what the current treatment, and look for the risk factors of asthma-related death, such as history of intubation, overuse of SABA, poor adherence to written asthma action plan, psychiatric disorder, not using or recently stopped ICS. Following are the signs of severe asthma exacerbation, such as sit forward, speak inwards or short phrases, usage of accessory muscles, agitation or altered consciousness, tachypnea, tachycardia, hypoxia, and finally silent chest. The following table shows the level of severity of acute exacerbation of asthma based on clinical features and clinical parameters. This is a logarithm management of acute asthma exacerbation at primary care based on GINA 2023. When patients present with acute or subacute asthma exacerbation at our primary care settings, we need to assess the patient. Is it asthma? Look for the factors for asthma-related death and assess the patient based on the severity of exacerbation, which is further divided into mild or moderate, severe asthma, or life-threatening asthma. If a patient has mild or moderate exacerbation of asthma, we can start treatment of SABA 4 to 10 puffs using spacer and repeat every 20 minutes for 1 hour. Along that, we can prescribe prednisolone and control oxygen, and target saturation is 93 to 95%. If patient presented to our clinic with severe asthma or life-threatening asthma, immediately we need to transfer this patient to acute care facility or tertiary center. While waiting to transfer, we can give SABA, ipratropium bromide, oxygen, and systemic corticosteroids. After starting the initial treatment for mild to moderate acute exacerbation of asthma, we need to assess the patient. If the symptom is worsening, we need to transfer this patient to acute care facilities. While waiting, we can continue giving SABA, ipratropium bromide, oxygen therapy, and systemic corticosteroids. After an hour of assessment, if the patient has improved, we need to assess the patient whether he is fit for discharge or not. We have to look at the symptoms and also PEF, whether it has improved or not. Ideally, the oxygen saturation should be more than 94% under room air, and we also have to ask about the resources at home, whether it's adequate or not adequate. If the patient is fit for discharge, then we have to advise the patient to use the reliever as needed If the patient is not started on controller, we need to start on controller. Or if the patient is on controller, we have to decide whether to step up the controller, check the inhaler technique and also the adherence. Prednisolone we can prescribe, usually used for 5 to 7 days, and we need to follow up this patient within 2 to 7 days. During follow-up at our clinic, we need to review the symptoms and sign. Is the exacerbation resolving, or should we continue the prednisolone? We also need to assess the usage of reliever and also controller during our follow-up. Also ask for the risk factor. We need to check and correct modifiable risk factor that may have contributed to exacerbation, including inhaler technique and adherence. We also need to assess whether the patient has clearly understood our written asthma action plan, or was it used appropriately, or does it need any modification? What is the role of IV magnesium sulfate in acute exacerbation of asthma? It is used as an adjunct in severe and life-threatening asthma. IV magnesium sulfate used in acute exacerbation of asthma, not responding to initial treatments. 2 systemic reviews and recent RCT showed that IV magnesium sulfate significantly improved pulmonary function and reduced hospitalization in acute asthma patients. Follow-up after an exacerbation. A follow-up appointment should be arranged for about 2 to 7 days later, depending on the clinical and social context. They should assess the patient's level of symptom control and risk factors, explore the potential cause of the exacerbation, and review the written asthma action plan. Inhaler technique and adherence should be reviewed before discharge. Discharge medication should include regular maintenance ICS containing treatment as needed reliever medication, and a short course of prednisolone. If the exacerbation was preceded by symptoms suggestive of chronically poorly controlled asthma, and inhaler technique and adherence are good, a step up in treatment may be indicated.
Now, let us discuss a case scenario. A 25-year-old woman, school teacher, non-smoker, presents with a 2-week history of shortness of breath and nocturnal cough to Klinik Kesihatan. She had URTI symptoms for past 2 weeks. She is a known case of asthma since age of 16 and on MDI salbutamol 2 puff PRN. Her last asthma exacerbation was 2 months ago and treated at Klinik Kesihatan. Her initial assessment, she was able to sit forward, speaks in phrases, not agitated, she was afebrile, not using accessory muscles. Her pulse rate was 115 beats per minute, her respiratory was 26 breaths per minute. Her blood pressure was 118/75. Her SpO2 was 93% under room air. On auscultation, she had minimal reduced breath sound bilaterally with generalized rhonchi. Question 1. What is the most likely diagnosis based on the case scenario given just now? Can you guess? The likely diagnosis will be acute exacerbation of asthma. Question 2. How would you grade the severity of exacerbation? Based on this table, it shows this lady falls under severity mild to moderate because she speaks in phrases, sits up and not agitated, and the clinical parameters as shown in the tables. Question 3. What are your immediate management in this case? Based on GINA guideline, mild to moderate cases, we need to start them on MDI salbutamol with spacer, oral prednisolone, and oxygen therapy. Hence, the correct answer for question 3 will be MDR salbutamol with spacer, oral prednisolone, and oxygen therapy. After 1 hour, she was reassessed again. Her symptoms has improved. She was able to talk in full sentences. Her pulse rate was 92, her respiratory was 16 breaths per minute, her blood pressure was 118/79, her SpO2 shows 98 to 99% under room air. On auscultation, equal air entry bilaterally and no rhonchi. Based on this assessment, we can arrange for a discharge in this case. Once patient fit for discharge, we have to explain patient to avoid triggering factors. We can start her on ICS formoterol MDI 1 puff twice daily and PRN basis. Explain to her about the MART or MAT therapy and asthma action plan. Continue trap prednisolone 30 mg daily for 5 days and to review her again in Klinik Kesehatan in 5 days. On day 5, she presented to our KK. She was well, no cough, no wheezing, no shortness of breath. She had good sleep at night. She has completed her third prednisolone. She uses ICS formoterol MDI 1 puff twice daily at home, able to do her daily activity at home without any limitations. Question 4. What are your management during her visit to Klinik Kesehatan? Yes, we need to check her PFR rate. We need to assess the ACT score in this case. Of course, we need to continue ICS plus LABA. We need to explain about written asthma action plan in this case. Remember, during follow-up, we need to assess her risk factor. Check and correct modifiable risk factors that may have contributed to exacerbations, including inhaler techniques and adherence.
Malaysian CPG Management of Asthma in Adults, published in 2017, and GINA Guideline, edition 2023, are the references used in this presentation. May this module will be helpful in managing of asthma patients in primary care. Thank you.